Today I'll be speaking on optimizing pain relief after vascular surgery from EVAR and CEA. I really appreciate the opportunity to be here. And I have no disclosures today. Today, our objectives will be looking at post-discharge opioid prescribing data from 2018 to 2021 for BMC2. We'll also work to define the 2022 goal as it relates to opioid prescribing for these two procedures, EVAR and CEA, particularly for opioid-naive patients. And then finally, we'll touch on some postoperative pain management strategies that really work to maximize recovery and emphasize the role of non-opioid approaches when it comes to helping people after surgery. So I'll just start out by introducing some other members of our team who couldn't be here today. I'm an anesthesiologist and pain medicine physician along with Chad Brummett. And then the Opioid Prescribing Engagement Network is also led by two other co-directors who are surgeons, Mike Inglesby and Jennifer Walgie. And then Beth Cease heads up most of our staff who provide the underbelly of the support for making the work that we do possible. And so we certainly appreciate the opportunity to collaborate with a number of organizations and quality collaborative initiatives, including BMC2. So again, much appreciation for being able to be here. As it relates to our work, the opioid prescribing guidelines are just one point among many lines of effort that we have when it comes to addressing opioid use, taking a preventative approach. We also do community outreach, naloxone training, really help with individuals who have complex opioid needs when they come into surgery and need to transition among different episodes of care. Dental opioid prescribing is a big source of exposure, especially for adolescents, and we have efforts there, along with what happens to individuals who transition when they take opioids to things like opioid use disorder. Some of our outreach also includes to high school students, and one of our co-directors, Chad Brummett, made a musical called Painless that is about to be distributed across the state here in the upcoming season to help engage high school students and help them be aware about the issues that can come up with opioids. And then activities like this that work with provider education and then informing policy as well. So you can see a pretty broad swath here. As it relates to getting to the prescribing goals and targets, we'll take a moment to review the data and the kind of metrics for 2018 to 2021. First, let's start out by looking at kind of where we've been, and that'll help inform where we might be going. For 2018, really, the focus was on establishing the goal. And so I'll turn your attention to here on the right side of the slide. Really, what we're talking about applies mainly to opioid-naive patients. So patients who are not taking opioids within 30 days of the hospital admission. There are various ways to find this out. One certainly by patient report. Another, certainly could check in the prescription drug monitoring program here in Michigan called MAPS to figure that out. But that's really the central group that we're talking about. Those who have opioid exposures represent a bit of a unique population that that these metrics, really may not be that applicable to. For both cases for EVAR and asymptomatic CEA, in 2018, the focus was on 10 or less pills at discharge and really getting that out there. The next year in 2019, established kind of a metric that the group was looking to go after with greater than 70% of the cases applying those same metrics to. And then in 2018, continued on with the same target there for those procedures. And in 2021, really upped the ante with a greater than 80% of cases as it related to that target. So you can see clear progress there. So today we're going to discuss, 22 and beyond. So changes to prescribing for these opioid-naive patients. The intention was to begin in January 1 of this year and help inform that. Again, really the goal is to take the opioid prescribing and help decrease that metric from the metrics that's being captured from a goal of 10 down to a goal of 4 pills or less at discharge after these two procedures. We can talk for a moment about kind of what the rationale is behind that. And then we also need to cover a little bit about helping patients recover when they get 4 or less pills as well. So opioid-naive patients were prescribed after elective EVAR. Here's data from 2019 from BMC2. And looking at the number of people who got less than or 10 opioid pills at discharge, and the number of people who got prescribed less than or equal to 4. And so you can see in 2019, we're just a little bit more than 70% of patients had the less than 10 mark, and about 60% of patients were actually meeting the less than 4 mark. Next year, remember, up the ante a bit with that goal, and here we're getting up to 86% for the less than 10, the less than 4 still in the 60s. And then over here for 2021, coming up to Q3, 90% of people were getting less than or equal to 10 pills, so did an excellent job across the group with engaging folks to make that happen, while the less than 4 was still staying about the same, about 60%. And you can see how that contrast happens, right? The less than 10 is we're really well in achieving that goal. Less than 4 still staying pretty consistent at the 60% there. And when we look at data for asymptomatic CEA, you can start to see a parallel trend, right? The less than 10 opioid pills at discharge raising from 71% up to 90%, so great job there. Less than 4 pills at discharge still staying flat in the 60% there. So I think that provides a pretty strong foundation for this year's focus on helping to get prescribing to less than or equal to 4 pills based on that data, and reviewing that data I think is an important part of that. Really, this is meant again to apply to the elective, EVAR's elective asymptomatic CEAs. 60% of these cases were already prescribed 4 or fewer pills at discharge, and so that's still a majority of patients, and it makes sense to focus on that group and try to help raise that number to more individuals. And part of the question that comes up naturally then is, how would you make that happen? So I think there are a few teaching points to cover to help patients recover better. And I think the first one to think about is to just start by thinking through your process. And that can be both at a practice level, hospital level, or organizational level. And so these patients have various touch points along the way. Before their hospital time in the hospital, time for the procedure, where their expectations about what's happening get shaped. They have interactions with various staff, both including clinical staff as well as non-clinical staff. They receive various materials from our organizations. It's not to say that any one of these really is the one that's going to make the difference, but altogether they do need to be considered about what kind of process a patient goes through as they come into their surgery, the various touch points that they have, and how those can be utilized to your advantage to make a difference when we're trying to enhance individuals' recovery, both for pain as well as other things besides pain that is there. I mentioned a little bit about expectations already, but really helping patients to understand what their process and procedure is going to be like is a critical part to helping ensure the success of pain control. Trying to help them understand both what the procedure entails, what is normal for a patient, what they should anticipate, what is kind of out of the ordinary, I think are very important ways to make that happen. That can come directly from the surgical team. It can come from materials that are provided to the patients. But we also know that our perioperative teams play a large role in terms of shaping and normalizing that. That can include certainly our physician extenders, whether they're physician assistants, nurses who are helping in terms of providing education or care for patients, in particular after surgery in the PACU, but also beforehand, seeing them in clinic, as well as helping individuals to kind of understand kind of where their pain fits in with that of others that are out there. Finally, if we're trying to help teach patients to recover, it's important to consider this as a team-based effort here, right? That there are multiple individuals to think about pulling in. And I've mentioned some of them on the organizational side of things. Those can be the team members who both provide direct clinical care, as well as others who provide services that directly support that role, whether it's someone who's checking in at the front desk, someone who's helping a patient get to where they need to go, or our nursing and physician assistants colleagues as well. But also we have other team members that we can engage who also come into the clinic visit as well. And those can be the friends, the family of the patients, and helping to engage them a little bit in terms of some of these conversations about pain, recovery, and the plan for what's going to happen afterwards. And I think we found success in terms of engaging those groups of individuals across organizations in the state, both with other CQIs as well, to help ensure the success when it comes to making changes for opioid prescribing. A bit about some just practical aspects for non-opioid medications. Here, focusing on acetaminophen and non-steroidal anti-inflammatory drugs. right? They're both common, they're available over the counter. It's important for us to emphasize them with patients. And when we do so, it's important that we encourage that they're used to be taken around the clock when possible. Helping people understand their availability and kind of their maximum dosing with these is important. People are sometimes surprised to understand that in a limited basis, it's fine for individuals under 65 to take up to 4 grams of acetaminophen a day. For those over 65, somewhere between 3 to 4 grams of acetaminophen a day. And that's a large number of pills of acetaminophen to take, plus the non-steroidal anti-inflammatory drugs that they could take as well. On the next slide. There we go. Total daily dosing, as I was mentioning, that most patients can get up to the 4,000 milligrams a day. 4 doses of 1,000 milligrams is something that you can prescribe. So you can hand them a prescription if they like to fill it. Many patients will take this to the pharmacy, and then they can have a conversation to see, is that less expensive to fill through their insurance versus pick it up over the counter. But given the act of giving a prescription likely helps to elevate that medication in a patient's mind. And again, whether they get over the counter or prescribed doesn't really matter as long as the utilization and help to take that medication. We also know that there's a bit of a synergy between non-steroidal anti-inflammatory drugs and acetaminophen. And so it's best when they're both taken together. Some people will alternate the pills in terms of taking them so patients have more experiences of taking doses. The other alternative I think that we're really recommending though to pursue is to take them both at the same time to help get that added analgesic effect. And that's the case where if NSAIDs provide a degree of pain relief and acetaminophen does as well, when you give them both at the same time, the pain relief is larger than either one anticipated together. Provide a few resources here showing that, but the combination also when we compare them to individual opioid pills ends up being better as well. I think those messages to patients are helpful for them to hear. Many of them find that surprising and aren't necessarily aware of that. So it's also important to help clarify that the order matters. I think those in the audience, likely already appreciate this and already think, oh, yeah, of course, this makes sense. What we find is when we speak with patients, though, in particular, whether it's before surgery or in the recovery area, that they're not always clear about this. And so it's worth helping to integrate into your workflows and protocols, or consider doing so, a special emphasis about how to take these medications through visual means, through other means, and reinforcing that along the multiple touch points that we have with patients. So when individuals do need to take analgesics to manage pain, the first line and go-tos really should be the acetaminophen and the NSAIDs. Like we mentioned before, they can be taken together, they can be taken around the clock. And then only when needed, then would the opioid analgesics come into play after that. We do see some confusion out there that patients don't always have an appreciation that those can be taken together, both the acetaminophen and NSAIDs, or that it's okay to take those two, and if the breakthrough pain happens, then to take the opioid pills. But it's important to help reframe that the opioid pills are more of for a step up in an intense pain situation, and really by the first 24 hours after their procedure, the pain should be in a place where their medication needs really shouldn't need opioids after that. I did want to let you all know about some resources that you have access to. So the Opioid Prescribing Engagement Network collaborates with a number of organizations to provide brochures about managing pain after surgery. And so these are enduring materials on our website that you can download, print off, and use, but also know that there's an option to customize these for your own organization and practice. And our group is happy to help facilitate that. We have dedicated resources to make that happen. We don't have funding to print them all off for you, but we can certainly help make print copies such that you could send them to press and get brochures for your group if you'd like your own organization's logo on them, to personalize them and kind of have that touch on them. They detail a number of these aspects that we're touching on today. Like I mentioned, this one's about managing pain after surgery. We also have one on opioids and pain management that also reinforces some aspects we didn't have time to touch on today about disposal, how to safely store them, what facts about opioids they should know, and things of that nature. That's also customizable, and a link here on the website and can provide that to you. Also put a mention in that medications are certainly one option in terms of helping to manage pain after surgery, though they're not certainly the only way to do that. And we're finding more and more patients are expressing interest in non-drug, non-pharmacologic methods about helping with their pain. And so we also have resources that can be used to help provide those. And those can be things as simple as mindful breathing, having a plan to take time out for reflection or other planned activities that take up their time. Meditation has its certainly adherents and practitioners, even going for a walk and helping patients be ambulatory to the extent that is safe after their procedures. Making sure that patients have a plan for some of these, I think, ends up being one of the more important aspects of helping to integrate this with their experience. I'll shift as we're here to close as we get ready to take some questions and mention that the Opioid Prescribing Engagement Network has a nice initiative dedicated about surgical opioid prescribing education. And I want to let you know that as a physician in BMC2, the vascular surgeons who participate would qualify for a special program. And so to let you know, if you have interest in signing up, we're offering sessions that are tailored, one-on-one sessions where for 30 minutes, you'd be able to learn a little bit more about opioid prescribing that's specific to your practice. So it's really meant to be tailored to your needs, your questions, and how your practice is. There is an incentive payment available for physicians within BMC2 who are vascular surgeons to participate, who participate in the session and then complete a follow-up survey. You would be able to achieve continuing medical education credit for that. It does nicely count towards the pain management requirement that the state has. And then there's also the availability to have follow-up support after this experience if it's needed or if you'd like it. And so I believe today in the audience, you should have these kind of informational cards. There's a QR code on there that if you scan it, it kind of prompts you in to help complete some information about that, or there's a URL on this page that you could visit that does the same area there. So I wanted to just conclude and say, it's certainly been a pleasure to be here and virtually and express some of this information with you, share some of the work that in goals and guidelines within BMC2 that the community has been really great, made really tremendous progress over the last couple of years in terms of the 10 opioid prescribing pill, and now with a wonderful goal of moving it to 4, which seems very appropriate. And talking about different ways to achieve that. And so just know that our organization, whether it's myself or others, are committed to being here as a resource as you and your organizations work to make change. We certainly want to be effective partners with you, and want to again thank you for your time here as we open it up for questions.
Thanks again. Use your microphone if you have any questions that come up.
One question. Not sure if you can hear me. Yeah.
Yeah, the audio is coming through great. Thank you.
Great. Is there any recommendation on what opioids should be used?
Yeah, it's a great question. So there are a couple of trains of thought here about what opioids to prescribe. I'd say the conventional practice at this point in time, the vast majority of patients are receiving likely hydrocodone about 2/3 of the time, or oxycodone about 1/4 of the time. The hydrocodone products in the United States all contain acetaminophen. And I think from our standpoint, when we speak with surgeons or others about this, one of the concerns that we have about products that contain acetaminophen is that it's very difficult for anybody, very difficult for me, let alone many of the patients that I think we see, to come in and try to understand how much acetaminophen or Tylenol can I take after I've taken some hydrocodone, or if it's included in my regimen, without necessarily going over that 4,000 milligram limit. By wedding those two together, I think we also kind of anchor people to say, well, look, this pill contains both of them, which is great. So you just take this one pill that has both, and the both are an opioid. The both aren't in Tylenol and NSAID together. So for that reason, we typically recommend individuals prescribe opioid pills. They just prescribe opioid only. And so a product that is just opioid, like oxycodone, even though oxycodone has a slightly greater morphine milligram equivalency, most patients from the research we found think of a pill as a pill as a pill. And so the fact that someone gets 4 of oxycodone versus 4 of hydrocodone, there's a slight difference in the calculation if you're going to be, scientific and analytical about it. But typically, we would say, okay, shift towards the opioid-only formulations, like an oxycodone 5. You could do like a morphine 5, but morphine has a little bit a larger histamine release, and so sometimes the side effects are a little bit more pronounced with that. And so I'd say, in general, though, those are the recommendations in terms of trying to help shape about what pills they get to help enable that other side of the conversation when it comes to emphasizing some of the non-opioid medication alternatives. Does that help? Great.
Questions?
Preoperative guided imagery passe, I mean, it has been shown to use perioperative pain and anxiety. It seems like carotid endarterectomy would be a perfect procedure like cabbage for preoperative guided imagery. Likewise, EVAR. Are you guys looking into this?
I caught the first part of that was talking about the preoperative anxiety and another component. I don't know if there's a way to just say that part of the question one more time. Sorry about that.
The value of preoperative guided imagery.
Oh, preoperative guided imagery. Yeah. Okay, that's a great point. It's interesting. We are seeing individuals who, in some smaller studies that are in the process of either being published or coming out, where there are interventions that directly address anxiety, or someone's kind of expected course through surgery. And preoperative guided imagery is one of those methods where individuals either in their mind can focus on different aspects through their preoperative experience, and or go a little bit more accustomed to understanding. A related issue is understanding kind of the process that they're going to go through, and kind of what steps they'll see, what sounds they'll have, what their experiences will be. And generally speaking, those have been very promising, I think, avenues to explore. I don't think we necessarily have an app just yet that we're out there trying to recommend, either from us or organizations, but it certainly is, I think, an active area, especially for patients who express an interest with, to encourage them to pursue those opportunities.
I guess this is a question for the audience here, actually, more than for you, but I was just curious, among all the vascular surgeons here and vascular providers, who uses local at the end of the carotid if it's under general anesthesia? How many of you are still in case versus who aren't? So show of hands, who uses local at the end? Maybe about half. It's like, so, I mean, does anyone have an opinions that it's affected the use of opiates in the hospital for them? Is that something you routinely recommend from the M-Open, that we start using local for all these cases at the end, even if they've had general anesthetic?
Yeah.
Could you hear that question?
Yeah, I would. Thank you. I didn't realize. I couldn't tell if the question was for audience member or back to me. Talking about the experience of the patients. I think we would say most of our research up to now that has tried to explore and tease out a relationship between the operative experience, whether it's local, a regional anesthetic versus general anesthetic, and then individuals' experiences afterwards, are that what we've seen for most surgeries, not just specific to vascular surgery, but others, are that both experiences can equip patients to be in good positions to recover without the significant use of opioids. One thing that we've picked up on a bit with some signals that we're still trying to, I think, fully flesh out, is that for some patients who go through protocols that end up involving just local or regional only, there's a bit more patient engagement and or education crafted towards their experiences, just like that question before about the guided imagery, about here's kind of what you're going to experience and here are ways that you can prepare for that and kind of how that's going to go through. And whether that is just with, limited to just the local and the regional versus when patients with general anesthetic also get explanations like that, It's unclear to us, like, is it actually the type of anesthesia, or is it that modification that sometimes happens with patients' experiences through that helps them to recover a little bit better. That being said, I think, practices that have comfort right now doing it one way or the other certainly should, I think, raise questions about how they integrate along various points of their pathway various ways to emphasize non-opioid medications, both before, during, and after surgery as appropriate. And that would probably be, at least seems to me, a little bit more practical place to start, as opposed to a wholesale change of, okay, you need to change your practice from just using, general anesthesia over to local and regional, one way versus the other. Because certainly practice patterns out there can vary, but at least to this point in time, we haven't seen a strong enough signal to say, okay, convincingly, we need to modify that right now.